Hello. Haji. Sajda, can you hear us?
Yes, we
Okay.
can hear you.
Okay, thank you. Chalo, okay. ठीक.
पेशेंट का बता दो.
Okay, I'm starting the case. This is a 40-year-old gentleman who presented to us in OPD with a complaint of pain in the epigastrium and yellowish discoloration of sclera for 2 months and itching all over the body for 1 month. He had his ultrasound done, which showed a dilated CBD of 1.1 centimeter with a single stone in the distal CBD. His LFTs were done and LFTs showed a total bilirubin of 1.2 with a direct of 0.9 and alkaline phosphatase is 237. INR is 1.04 and all the other labs are within a normal limit. So the patient was admitted for ERCP and we are going to proceed with the ERCP.
Okay. Right, thank you very much. Okay.
ओके. क्योंकि टांग मोड़ो. ठीक है, आराम से लेटना है. अभी प्रोसेस शुरू कर रहे हैं.
Chalo ji. Thank you, Rashmi. Right. On air, am?
और सर.
Huh? On? Acha. Before we insert the scope, it's always good practice to check your scope function first. So we check for air flow, you check for water jet over the lens so that it's cleaning the lens, and you check for suction. You also check for the light, that the light is transmitted normally. और उसके बाद we just introduce the scope over the patient's tongue and try to insert.
पीछे
शाबाश.
पीछे. शाबाश. हाँ, पिए पानी पानी.
Number, हाँ, शाबाश, good. So,
बस बस आराम से.
हाँ,
आराम से.
हाँ, शाबाश.
पानी पिए.
हाँ, और मेरा स्ट्रगल कर रहा है. थोड़ा सा स्ट्रगल कर रहा है. शाबाश, आराम से.
आराम से.
हाँ, शाबाश. हाँ, हाँ, सेडेशन थोड़ा सा दे देना. हाँ, हाँ. ओके.
बस 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 भैया बस बस. पानी पिए.
हाँ, पानी पिए. शाबाश. मेरे को वो करे, स्ट्रगल करे, थोड़ा सेडेशन ज़्यादा दे देना.
बस 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 आराम से. उसको लगा के रखें.
हाँ, 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 वो दे दे थोड़ा सा.
और दे.
क्योंकि
अरे डायरेक्ट वहाँ से पेमेंट क्या करेंगे.
ओके. चलो,
बस आराम
चलो.
से.
हाँ, आराम से लंबा सांस लें. शाबाश. हाँ, हाँ, और शाबाश.
जाने दें.
हाँ.
जाने दें इसको. इसको जाने दें. पानी पिए. पानी पिए. शाबाश. बड़ा फूल करें. पानी पिए. बस पानी पिए. पानी.
आराम से लेटिए, ऐसे मत करें, आराम से लेटिए.
हाँ, हाँ. थोड़ा सा ऐसे करो इसको.
जोर नहीं लगाएं, सटीक जोर मत लगाएं, आराम से
हाँ,
लेटिए.
ऐसे साइड पे कर दें.
आराम से लेटे बिल्कुल.
हाँ, बिल्कुल. हाँ,
सांस
शाबाश.
ले आराम आराम से. सांस लेते रहो, पानी आराम आराम से.
इसका यार दांत
इसको
लगता है.
आराम से लेटे. शाबाश.
हाँ, ये सही
ये
है.
हाँ,
बस जोर नहीं लगाएं, आराम से लेटे.
हाँ,
कुछ भी
हाँ,
नहीं
आराम
होगा
से.
आपके
हाँ,
साथ.
शाबाश.
बस सांस पी लें,
पानी
पी
पिए.
लें,
शाबाश.
पी लें. गुड.
Okay, that's fine. Okay, shabash, well done. Okay, ठीक. Right, we just intubated the patient. There's a bit of struggle because I think he was resisting the thing. So I'm.
Dr. Bakar, how
Ji,
much
ji.
sedation was given initially?
I think they had sedated him, but unfortunately he had been sedated for about 20 minutes before we actually came. So some of the effect was wearing off. Right, so I'm in the stomach now.
Can we have the endo view?
Yeah. Right, we just got the end of view there, and I'm just following the gastric folds to get towards the pylorus. There's a slight torsion of the stomach. So it just is. Okay. Right, you can see the pylorus right in front, and the way to intubate a pylorus is by making it look like a setting sun. So when you approach the pylorus, it should look like a setting sun towards you, as if the sun is setting down in front of your eyes. So, right. So we go towards into the duodenum, and right. We've just got a view of the papilla, and I'm just going to set my position first. So get it into the right position, and then have a good look at the papilla. Right. Screen करें भाई.
Hello.
I'm okay. Fine.
Hello. Hello. Hello.
Okay, fine. Thank you. Thank you. Right, so you can see the papilla there. Get a close view of it and make sure that you get a good view and a good position, and try not to mess around with it unnecessarily. So we'll get the position thing. हाँ भाई, cannula.
Waqar bhai, can you hear me?
Yes.
Okay, so I'm here. So with regard to the
ये
papilla,
ओपिन किया कि नहीं?
what do you see?
हाँ हाँ देना है. मैं तो बस खुपान का आदमी हूँ दारे मुझसे बगैर रूटीन पे कराते हो. हाँ हाँ जितना दिल करे दो यार, जो भी हाँ मतलब जो स्टैंडर्ड डोज है. हाँ हाँ अच्छा थोड़ा सा ये वायर निकाले बाहर से. So we just let the wire stick out a touch, yeah? हाँ इतना काफ़ी है. ठीक है. ठीक है. So we get the scope in position. You can see the winking papilla. Right. Okay.
So
अब थोड़ा सा एडवांस करें. सॉरी ये क्या किया? हाँ कौन सा? अच्छा फ्लोरो है किधर है?
ये फ्लोरो है सर, ये
हाँ
आपके
अच्छा अच्छा हाँ ज़रा एडवांस करें.
Hello.
हाँ
Hello.
फुल हाँ ठहरे
Hello.
थोड़ा सा 1 मिनट.
Hello.
या राइट ओके. फिर वायर निकालें बाहर.
Hello. 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 Just one. Hello. Hello. Testing.
So
Hello.
you see
Hello.
the angle of the you see the angle of the sphincter
वो
tone.
आगे
Where do you
एडवांस
think
करें वहाँ.
like here this is a fold
Okay.
right there. This is a fold. To me it looks like
हाँ हाँ हाँ.
so right there looks like this should be the direction of the body. You agree?
अच्छा.
Okay. So that's
ठीक है.
he probably is
advance
trying to
करें वहाँ.
achieve that right now. Here angle looks
ये
good.
वाला.
Sphincter tone angle
किधर जा रहा
looks good. It doesn't look bad because this should be the direction of the body. And if you are going in pancreas, it's going to be like this. Okay? Right there. This angle, now he got engaged in pretty nicely right there. Maybe if he's not able to get the wire in there,
थोड़ा सा इंजेक्ट करें मामूली सा. पीली है ना? हाँ ठीक है.
because of the multiple folds
Completely.
in
We are
there.
going there.
Yeah,
ठीक है.
so it's
थोड़ा सा वो कर दें.
inside the bile duct is at
ये
an
वायर
angle.
निकालें बाहर.
That's why. So to get the idea about the anatomy and the angle and the axis, sometimes you have to inject if the wire is not going straight in there.
अभी जो है ना ये कॉन्टेक्ट सुपरफिशियल, इट्स नॉट लाइक सीडेड इन.
इधर ज़रा एडवांस करें.
The wire is coming out.
Yes, yeah, sorry.
Okay.
I think I'm still not having.
So
इसमें
it's
थोड़ा सा जो
I think
इसका
there
जो
are
एंगल है ना, इसको थोड़ा सा एडजस्ट करेंगे. वो उधर का नजर नहीं आ रहा मुझे, वायर जो जा रही है.
तो इस
थोड़ा सा वायर निकालें फिर.
डेक को भी ध्यान रखना चाहिए कि not pushing the wire and it's
ठीक है.
just coming out. Yeah.
और भी निकालें
और कई
वायर.
दफा वायर को रोटेट करें ना तो it finds iron.
Okay.
And every wire can be rotated.
अब एडवांस करें. ये किधर हाँ हाँ पीडी उसमें. हाँ ये क्या पीडी जा रहा है. इसका सारा स्कोप के पीछे जा रहा है. ये क्या चक्कर है.
So it looks like it.
I
Can you hear us?
can't see the wire. It's, I think going behind the scope. There's a bit of a problem with the angle of. अच्छा.
Hello?
Hello. Yeah.
You can hear us, right?
Yes, we can hear you. Yes.
Okay.
Yeah. अच्छा.
So your plan is to engage it and inject. I see a lot of folds there.
Yes. Yeah. It's just that I can't see the. I think the wire is the projection is a bit off because this wire is going behind the scope most of the time. So I'm just trying to adjust that.
And there are multiple folds. so
Yes,
it's
I know.
gonna be- Yeah,
Yeah,
exactly.
that's what we want
So
to.
that's making it a
Yes,
little more.
that's right. Yeah. Wire निकाले बाहर शाबाश. हाँ. अच्छा ठीक है. एक मिनट.
इस तरह की film is sometimes not using a wire tape and getting a regular panel might straighten it. Right? So good, yeah, if I'm not able to cannulate in 5 minutes or so after a few attempts, and start thinking what's the backup plan if cannot get it cannulated.
एडवांस करें थोड़ा सा. एक मिनट. इधर था इधर रोक ले. मैं ज़रा उसको एंगेज करूँ कैनुला को. ठीक है.
Now,
अब
now it looks pretty nicely
yes, yeah,
engaged
yeah,
there.
अब एडवांस करें वायर थोड़ा सा. हाँ ठीक है. अब ये अच्छा इधर वो कर लें. थोड़ा सा इंजेक्ट कर लें कॉन्ट्रास्ट. ठीक. हाँ रेडी. एक मिनट. अभी इंजेक्ट ना करें. पहले इंजेक्ट. हाँ अब इंजेक्ट करें. हाँ उसको वो. हाँ इंजेक्ट. हाँ ठीक. हाँ 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 बस स्टॉप. ठीक. अच्छा इसको थोड़ा सा मैं खींचता हूँ. आप थोड़ा सा वायर एडवांस करें. हाँ थोड़ा सा. हाँ अब एडवांस करें. शाबाश. जेंटली. हाँ मैं थोड़ा सा इस पर खींच डालता हूँ. प्रेशर. हाँ 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 हाँ. नो. अच्छा ठीक है. सॉरी. इट्स जस्ट. हाँ विड्रॉ. ठीक है. हाँ अब इसको. अब दोबारा से मैं इसको. अब आप मैं इसको खींचता हूँ ज़रा सा. आप इसको थोड़ा सा आगे वो करें. हाँ एडवांस. हाँ हाँ एडवांस. थोड़ा सा मैं इसको और खींचता हूँ. हाँ ओके ठीक. ओ सॉरी. अच्छा अब मामूली सा इन वो एडवांस करें वायर. शाबाश.
But this is a normal human, so I don't know if it's a
फुल बैक में. अच्छा ठीक है. एक मिनट. अब करें. शाबाश. हाँ एडवांस. हाँ अच्छा नो. अच्छा इसमें थोड़ा सा आप इस वक्त इंजेक्ट करें ज़रा. इंजेक्ट. स्टार्ट सा. अच्छा ये. हाँ स्टॉप 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 स्टॉप. सो या. अच्छा अब वायर एडवांस करें. निकालें बाहर. शाबाश. अच्छा ठीक है। थोड़ा सा एडवांस करें। इट्स नो पीडी। अच्छा विड्रॉ। वायर निकालें बाहर। हाँ ठीक है, क्या बात, इतना ज़्यादा नहीं, हाँ इतना कम।
यहाँ पे बबल से बिल्कुल नीचे, राइट, दिस इज
अच्छा इधर एडवांस करें। हाँ
भैया आराम से लेना, ऐसे नहीं करेंगे।
अच्छा
नीचे रखिए।
आराम से आराम से आराम से थोड़ा सा इसको भी ड्रॉ करें। हाँ हाँ अच्छा ये ज़रा, हाँ ओके। अब मामूली सा इंजेक्ट कर दें। स्टॉप। अच्छा 1 मिनट अभी मैं वो करूँ फिर। हाँ अब इंजेक्ट करें। स्टार्ट। हाँ हाँ स्लोली इंजेक्ट। हाँ स्टॉप। हाँ वो खैर बाहर ही निकल आया था। अच्छा वो वायर निकालें बाहर। यार थोड़ा सा एट्रोपिन दे दें।
रीमा, one और दो।
Continuous contraction only, we can give appropriate.
If that's what he asked for.
We routine.
Right. Okay.
Today the patients are actually not under propofol, so it's not. Mostly in propofol procedures and we have a problem.
बस बस आराम से रखिए।
So just remember that if you're having trouble getting in, don't get impatient. More time to spend, more
थोड़ा सा
nervous, more not nervous, more anxious. And then we start doing
हाँ जी अब हाँ वायर निकालें थोड़ा। शाबाश दैट्स गुड।
should not do pressing on it, exploring the patella. And just take your time, relax, take a deep breath, and start over every time you're not able to get in. And if you're not able to get in with this, it keeps going into the pancreas. We have to start thinking about maybe use a straighter cannula or start thinking what else you can do. Can you get the wire in the pancreas and then put a stent in the or do a double wire or put a stent in the
सॉरी थोड़ा सा वायर एडवांस करें। शाबाश। हाँ एडवांस शाबाश।
when needed, you do it, but you have to do it in a proper way, proper circumstances.
सॉरी हाँ
Yes, absolutely.
तो
When you've done enough, you would know when you will
When
not
you
get
need
it.
to. And
ये
you should not
वायर
be
निकालें थोड़ा।
We will say, okay,
ठीक है।
fine. Khalid will have his own threshold, I have my own threshold, but more or less almost a similar kind of time, and we'll be thinking, okay, it's not going, what do we do? Do we keep on playing with it, or do we just take to a needle knife? But remember, our needle knife experience, my needle knife experience goes back almost 23 years. And so there's, if you start doing needle knives,
इधर
your cannulation will
एडवांस
never be
करें।
90% is what we are talking about.
शाबाश।
So
थोड़ा सा
when your
इसको हाँ
cannulation
पुल बैक
rate is
पुल बैक। हाँ
98%,
अब
then
Try again, shabash.
So you might
हाँ.
require
Pull back
needle
थोड़ा सा.
knife in less than 10% of the cases.
Needle knife should not be more than 10%. If it's more than 10%,
Up.
then there's a problem.
And then like it's time like and that is like
अंदर
really
जा रहे
you
हैं.
are at least more than 95% of the time you're in.
Wire out.
Sorry?
Minimum cannulation rate should be more than 95% before you start thinking about hypertension. And don't use needle knife unless you've done 4 to 500 ERCPs. So just at least that amount of ERCPs. You are gonna fail multiple times. Let somebody else do it who can probably do a better job. And when I would suggest like minimum 400 ERCPs before you pick up a needle.
Threshold in Pakistan is
In Pakistan, what?
थोड़ा सा sedation थी क्या?
you've done like
I did not do my needle knife until I had done 400 ERCPs. I was not allowed to. And after 400 ERCPs,
हाँ. थोड़ा सा हाँ wire हाँ ठीक है. Right, okay.
she started doing needle knife after she did
after
800
100
kg.
So we don't like we should not.
But the trainees who came to our course started doing them much before.
Advance करें शाबाश.
And that's one of the
Yeah.
Yeah, now at least
PD
they're
में जा रहे हैं.
pancreas.
ठीक है हाँ वापस withdraw.
So now you are in the pancreas.
Yes, yeah.
Good. So what is your plan to do? Like leave the wire in there, put a stent in there, or?
I think I'll still try make one more attempt at if I can go straight in the CBD. So I'll put it back.
I don't know the demographics of this patient, but looking at the PD diameter, this patient is at risk of pancreatitis. It's a very small PD, multiple attempts. It's not really, I don't think I'm worried about the contrast. I'm worried more about the trauma to the ampulla, which is going to lead to edema and mechanical obstruction. So if I will discuss it further, but here, they got the wire out. So I would have, I personally, in this case, if I have the wire that deep in there, I will put a stent in there and then go from it. And especially after this much attempt and injecting it as well.
आवाज़ इको कर रही है जब हम बात करते हैं तो वहाँ पे जब यहाँ से भी बात करते हैं तो एकदम से वॉल्यूम हो जाता है तो देर से होता है अभी ठीक कर रहे हैं
I turned it up. Actually, they can hear.
What will you do? Okay.
अब try करें.
For such a long time.
हाँ वही.
And
ठीक है. मेरे ख्याल ये वायर इधर ही छोड़ जाते हैं आगे एडवांस करें.
And then you have two options. One after
ठीक है.
putting the wire
अब
in the
इसको
pancreas.
वायर एक्सचेंज कर देते हैं.
Try and put the wire in the CBD sometimes, like you said, to double wire technique, you could get in. Otherwise, like Khalid said, you could actually put a stent in there, pancreatic stent in there, and then carry on with your procedure. And the third option is that I probably would have done a needle knife a little before if I had already. If I don't get into the ampulla within 3 minutes, I know I'll not get. Usually 3 minutes is all I give myself. But then that's something that's with almost 2.5 decades of experience.
Yeah, so
So I wouldn't say 3 minutes because I know that I'm more likely to harm than benefit my patient. Obviously, in those 3 minutes, you would have seen this ampulla. The moment you see it, you say, this is going to be tricky. So you already start thinking कि मेरा next line of action क्या होगा?
हाँ,
आप
दूसरा
इतना
होगा।
experience आपको हो जाता है कि this ampulla is in the moment, and because this is a course, maybe he's
अच्छा ठीक है.
also not doing exactly what he would do in practice. So a lot of times when we are teaching, we sometimes don't do just to show you, but in our own practices sometimes it's different. So you have all the options, like you said, trying a cannula in this kind of an ampulla might work. Putting a wire stent trying then might work. You can put a stent in the pancreatic duct, then do a needle knife, so it'd be much safer. You've protected your pancreatic duct.
थोड़ा सा addition ले देखिए.
There are people who do a pancreatic sphincterotomy here, put a pancreatic stent, okay, and then actually go. So that's not needle knife, but that's kind of de-roofing the ampulla. The only problem here is the ampulla is very foldy, so you really need to de-roof it a lot before you can be comfortably able to get into CBD. So personally, I think he's trying the double wire technique already. You need to now maintain your access of the pancreatic duct. You don't want to leave this pancreatic duct alone, right? Unless it's a very thin-looking
Wire
pancreatic
advance
duct, normal
करने से
pancreatic duct. So
And that's one of the reasons, like whenever
हाँ एक मिनट चेक कर लीजिए.
needle first, always move that over
हाँ
the
ठीक है ठीक है राइट. और withdraw हाँ बस इतना छोड़ दें. हाँ
this case, the
ठीक है.
reason is, again, I would put a mechanic stent first because that way at least pancreas is safe. The most
आप
common
try करें.
complication is post-ERCP.
Again PV.
So now the pancreas, so now we really don't have much of an option. I think eventually you have to do the pancreas.
So, are you thinking like at some point putting a pancreatic stent and?
I was just about thinking about that because I thought I might just do it over the wire, but it seems that it keeps going there.
Yeah,
So it
I
might be a
was-
good idea to block
I-
the pancreatic duct with it.
How old is this patient? It's a female or?
It's a young man. How old is he? 30 something. हाँ एक मिनट. 40 odd.
40 mil.
ये जरा थोड़ा सा
Is it
वो दे
normal
दे.
or deranged?
एट्रोपिन दे दे.
And he's got a stone in the CBD.
एक मिनट जरा बाहर निकालें बाहर. हाँ हाँ अच्छा.
And this patient almost certainly in our unit will also get a suppository. We use what? We use Voltron. That will connect.
This indomethacin,
Indomethacin suppository is not available as far as I know.
there has been
So there is no study to show that it works.
हाँ जी. हाँ हाँ वायर करें. नो
It's going into pancreas. So
withdraw.
where should we go? He's going where we need to go, but it's not going.
So here, so you see, this is the fold right there. Okay. So nothing is beyond above that, right? It's in the right position. Just in this case, what I would do, one thing is after putting the wire in there, I will move this fold out before I touch it. So just to get the idea about the upper end of the abdomen. And then I will just go right at that edge where the normal that's what I meant. Like, he can see that right.
You can see it, it's not hiding.
Right
What
here.
he means is it gives you that little bit more space, but there are times when he's gone in with total clearance and still he's not been able to get in. So, I mean, there are ERCPs that are difficult, there are ERCPs that are easy. If every ERCP is taking you the same time and same issues, then obviously there is an issue, but anybody and everybody will get
We'll get like a mix something. It's
अच्छा अब एडवांस
I'll
करें.
show some slides about our study. We followed our 1,000 ERCPs, just like every ERCP which came in, and then
Check करें.
see how many normal, like first timers are.
हाँ 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 ठीक है.
And then M plus, M
मेरे ख्याल यहाँ पे स्टैंड डाल लेते हैं, ठीक है। अच्छा ये मैं विड्रॉ करता हूँ कैनुला, आप मुझे इस पे स्टैंड, हाँ हाँ सिंगल टिप पे छोटा सा दे दें ताकि बस सिर्फ ज़्यादा वो ना हो। हाँ 7 7 दे दें, जो भी हो मतलब उससे। We are just going to put a stent into the pancreatic duct, number one to prevent any future pancreatitis, and secondly to facilitate cannulation to the CBD.
Not been failed ERCPs elsewhere. We succeeded in some 93% in the first go, and the remaining were done in the second. Of those, 60% plus were not done by me. They were all done by Dr. Sajdar, Dr. Sharia, Dr. Ali, Dr. Arif Siddiq. Okay. And like you said, advanced techniques required were not more than 10-15%. And I'll tell you the biggest disappointment was that only yesterday I've done a case that was done, I'll show you the report as well. It was done in one of the big centers in this city. Failed pancreatic stent placed, difficult, pata nahi kya kya, what not. Cannulated in second go, procedure done in 7 minutes. Nothing. So that's a problem. If I had gone in and I had struggled, I had done a needle knife, he sends the patient to Khalid and Khalid says, oh, this is a difficult ampulla. This is a difficult ampulla, okay? Maybe I might have been lucky, but if you put this picture in front of everybody and with Wakar's experience, if he's having difficulty, then this is a difficult ampulla. I'm not just going to take his scope. I know this for a sure, for sure that मैं जाके scope ले लूँ और मैं कहूँ okay fine, I just put it in. That's not happening here. Okay? And that's fine. That will happen with me and everybody else. But if you do a case where you say you can't do it for 2.5 hours or 2 hours, and then I take 5 minutes to do it, then there is a problem. That's why these courses are there. That's why you need to go update yourself. That's why you need to understand your limitations.
And just the hardest thing to learn is when to stop. But once you learn that, you will succeed.
And to be honest, देखो मैं क्योंकि अभी आप लोग early career में हो ना, रेफर करने से पेशेंट किसी दूसरे आदमी को कभी भी आपकी प्रैक्टिस कम नहीं होगी. ट्रस्ट मी. जिसको आप रेफर कर रहे हो अव्वल तो उसको ज़रूरत ही नहीं है पेशेंट से. ठीक है, if he is so good, he doesn't need your patient. He is already full. Number one. Number two, he will have a good word to say about you.
सर हुआ मेरे साथ अक्सर लोग मेरे पास आए बाकी थैंक्स का मुझे कि आपने मुझे वहाँ भेजा और
तो इसलिए ये बहुत ज़रूरी है. That's important. And it's important for your patient. At the end of the day, why are you doing all this? ये मज़ा आ रहा है. You're doing it to help people.
so any center in Pakistan doing fellowship in ERCP?
In Shivjal hospital they have put the program, but this is not the.
I recommended to the FCPS we should have a one fellowship combined Lahore Karachi 2-year program because you need to be in a high volume center.
One doctor spent 1 year, whole 1 year there, doing all.
It's not about 1 year. It's about कितना time training के लिए है. We don't have time here to train. That's why we don't train now. Because on one list we have 12 ERCP.
Okay.
वो 12 ERCP में who has time to? I don't have time to talk. And then in my list, they're obviously failed, etc., etc. उसी में EOS भी चल रहा है, उसी में बीच में large polyp भी आ गया. So we are actually going through the 3 suites like crazy. उस बीच में कहाँ से सिखाएंगे? इस तरह खड़े होके तो मैंने किसी को नहीं सिखाया. So but because it's a high volume center, once you get in, You start doing reasonable numbers, so you get the numbers, and there is somebody to supervise you. That's why we can't start wala kaam nahi kar sakte. It's a bit difficult. Somebody who already has done a few, then you can come. To be fair, दो तीन चीज़ों का ख्याल रखना पड़ता है. मैं used to इस system का, मैं used to चीज़ों का यहाँ पे. जहाँ खालिद का यूनिट है, that's like Rolls Royce. वहाँ जाके मुझे लगता है मैं एंडोस्कोपी यूनिट में हुई नहीं. ठीक है ना? Their unit is like one of the best I've ever seen. Probably one of the best anywhere in the world. And so he's used to everything and anything. All he has to do is say, I need to have this, and he has it. Pakistani standard say our unit is like his unit. Here. So we have almost everything, but not like his. And similarly, उनकी अपनी systems होते हैं, अपने scopes होते हैं, अपनी चीज़ें होती हैं. तो इनको हम ला के वहाँ के environment से यहाँ डाल देते हैं. So to be honest, थोड़ा सा इनके साथ ज़्यादती करते हैं, लेकिन they cope up very well because they are very good. Similarly with Waqar, where he worked, I used to work in a small, not a very big unit, but I knew this much that मैं पाकिस्तान जब आया था तो मेरे unit में जो accessories थी वो पूरे पाकिस्तान के stock से ज़्यादा थी, सिर्फ मेरे एक unit में. So these are things that are important. If you're going to do cases that are difficult, you need to have all the accessories. I can't say, oh, listen, मैं कर लेता अगर मेरे पास ये चीज़ होती. वो acceptable नहीं है. फिर आपको पहले सोचना चाहिए. जब आप एक केस करने जा रहे हैं तो आपके पास सारी चीज़ें होनी चाहिए. तो काश मेरे पास एक वायर वो वाला होता, फिर वो वायर पहले ले लो ना. Invest on your accessories, that will give you better results. Don't invest on your accessories, you will not. Khalid, what will you do now?
I will personally need a time.
That's what I think Waqar would have done. If he was doing it by himself, he would have done it.
He probably would have done
Yeah,
especially you got the pancreatic stent.
Yeah, now you got a pancreatic stent, so you're okay. It's the trajectory, जो है ना, is throughout pancreas. Your pancreas. That's going to go to pancreas.
So I think, can you hear me? आवाज आ रही है आपको?
बाहर निकाले
थोड़ा सा इसमें पोजीशन का भी पोजीशनिंग इज ओके ओनली.
I think this is the best he could get. So looking there, it looks fine. Looking at the position of the ankle, it looks fine.
I think it's very good position.
Yeah, this is the best probably. And even though on the this image on X-ray, it's not at the best eye looking position, but that's not like that's not what I'm concerned about. Here, looking at endoscopy,
Yeah, it looks
it's a very good position.
Very good position. You've got good approach. You've got all your movements with you. And pull back. You can see he's using his big wheel, bringing forward. He's also using. So he's, all the things that. This is all good. It's just that it's a difficult.
And that's the main goal actually for the course is to get in the right position, do the right stuff, and have a right approach and.
Like you were saying, you can
right
actually literally see the opening completely here. So you can see it's just that the space is not there.
Yeah, right there. This is
Hello. Hello. Hello.
आपको आवाज आ रही है?
Hello.
मैं उन्हें ये कहना चाह रहा था कि
रेडी कर रहे हैं.
Hello.
Wakar bhai, can you hear me?
Yes, I can.
Yeah, so we were thinking it's really a difficult, challenging papilla. And in our practice, I'm pretty sure by now, if I was doing it or you were doing in your unit, you probably have started thinking about using a needle knife.
That's what
And,
exactly
yeah.
I asked them to get out for me now.
And yeah, because of the course, we're trying
yes,
not to use
Yeah,
that, but I
yeah.
think we're getting to the point
Yes,
that it's okay to go ahead and use it.
Yes, yeah. जा रहा है कि नहीं? हाँ, ये किधर है? Oh, sorry. हाँ नहीं, we are going to do a pre-cut क्योंकि we just discussed that amongst ourselves. हाँ, थोड़ा सा इधर करें.
Slightly different to what we have done so far, so it's just a little
Try करेंगे.
glimpse of possibility. But
Needle knife ready? अच्छा ठीक है. Right. Right. Okay.
So before you start cutting, can you get the, like when you get the needle into the patient, can you show us the direction you plan
Yes,
to
yeah.
cut?
I'll
And
do
do
that.
you plan to cut from top, bottom, or bottom up?
Yeah.
And you can show us that.
in your practice, do you go top bottom or bottom?
This one I might go from top because here it's a good bulge on the top, so I probably will go from top. What is your
Almost always.
No, I
Especially
don't
in
always go.
it's almost always I do that because in this case, so it's a little easier now because of the bankhead extending. So you just
And top to bottom should be not be done without a start. Like if you're
I was at a
I'll just show you from this view. If you see the direction of the common bile duct is from here to here like that, along that axis. Right, okay. So I'll then get it myself into position, and I'll do it from bottom top. Right. So needle out.
So he already showed the direction he's going to cut it, and he's going in the same direction. And you have to cut it layer by layer. And every time you cut one layer, then you should take another look right there. This is beautiful cut right there.
Okay.
And from here, what I would do is I will split that. Get the needle. See the opening. Right there, you always look for the red spot. Right there. This is the opening right here.
This is the opening for the CBD.
For the seat. You look for the red spot there.
And the red spot is during the muscle
What I meant was for that, what I just showed, like it's going to be a red spot and there's going to be a little muscular tissue.
I don't know. In your practice, do you then use a wire to get it after you've done a needle knife all the way?
If I
or do you
can see
just-
the opening.
Yeah, like for example, in this case, I would just put a wire up there.
This is like maybe you need to cut a little more. If this doesn't go,
Yes,
in,
it
then
doesn't.
I
Yeah,
can
it's
go.
See, that's beautiful.
So right that the red
Okay,
spot
that
there,
contrast?
that's when
CBD.
so you saw that here where the pointer where it was,
Okay.
that red spot. You see
Oh,
the
that's
opening, a
interesting.
little
Do we
bit
have-
tissue there.
What have we got in
And
this?
muscle.
This is a stricture. This doesn't look like a stone.
I think when
Okay,
they
so
do
we
a
are in the
little-
CBD now, eventually. Do a
Yeah,
proper
we
sequence.
see that that was a very nice needle knife. We could see
you.
the opening in there. So that, good job with that. So we are just wondering if there is a stricture distally or it's a stone. I think a balloon sweep would help
That's,
us better.
Yes, I'm not sure because it. Shall we try a bit more contrast there? That's what I thought. Whether the contrast or tracking alongside the stone or was it the stricture? इसको थोड़ा सा हाँ वो
Look at
करें
the CBD.
एक मिनट
It's coming like
Inject,
this.
inject.
It's kind of narrowing here.
हाँ ठीक है now it's better. You can see that. ठीक है हाँ वो कनेक्टेड है हम अच्छा ओके
Yeah, just remember that because of the position, sometimes this side doesn't feel very good. Because the right
Huh? Let me. वो तो हाँ फिल्टर तो कट गया.
always goes by these goals and those terms and everything. Everything is not going to be like that. Everything is not
बस
going
बस
to
हो
be
गया
per
almost.
7. So every patient is different. Most of the time you make it that, but every patient is different.
ठीक है इतना काफ़ी होगा. ठीक है फिर. अच्छा वायर एक्सचेंज.
It's hard to determine right
हाँ हो
now.
गया.
Hard to determine the
वायर ऊपर कर
something.
देना ठीक है.
So you have to be careful and this is the if the stone was big, this is kind of a papilla.
Especially because you've had difficulty. I usually would go with a balloon below the stone, pull it out. If it comes out and the balloon
हाँ
is
जी.
decent size and the
ठीक है
stone
balloon
is
दे.
is mobile, then I wouldn't do it. I would attempt with just a balloon. And if it doesn't come out, then I just put a balloon string to plastic. But in this particular case, because now
Adrenaline वगैरह है.
your anatomy and the
वो तो कोई ज़रूरत ना पड़ी क्योंकि
limit is a little
by the
bit
time ये
big.
निकालें तो वो खुद ही
Why
बंद
take
हो
a
जाता
chance
है.
when you have another option?
And if you really have to want to take a look at it, you can wash it too. And that would give you a better. It's not a really active
You're
bleeding.
probably up to here. You know, this fold is okay, but as I said, if you're not sure and you have another safer option, why take the difficult option? या तो कोई option ही नहीं है. When you have a better and safer option, always go for that.
So how will you predict the size of the stone?
How will you predict the size of stone? You look at the
The
Inflate.
scope diameter is
scope
11
diameter.
millimeter, 11 to 12 millimeter, and based on that you get
हाँ लॉक हाँ ठीक है. क्या चक्कर है.
Why doesn't it show that the stone is 0.9?
So it's not coming out.
Right.
That's not coming out. So you have two options. You go in
पत्थर
now.
बड़ा है.
He did exactly what I normally would
Huh?
do. Put a balloon, try and see if it doesn't
हाँ
work.
वही ना.
You just put a sphingloplasty balloon. You don't even have to do a lot here.
कुछ हुआ तो है.
In this difficult case, some people might
No,
place
no,
it.
it's not any. Oh, when I
हो गया जी. चलो ठीक. Good.
yes, go.
चलो. We got a stone out here. ठीक है. वो कर लेते हैं. Occlusion.
Vakar, can you hear me?
Hmm?
Vakar,
हाँ.
can you hear me?
Yes yeah.
Good job.
Thank you. Thank you. Occlusion को एंजियोग्राम कर लेते हैं ठीक है. वो हो गया प्राइम्ड है. अच्छा हाँ ठीक है.
So what do you do with the pancreatic stent?
जरा थोड़ा सा सेंटर करा दियो.
छोड़ दे भूल जाए.
सॉरी.
So you say
So, already over one
अच्छा
vote
ठीक है.
here.
Inflate balloon
we want a vote.
Yeah. So, who said
lock and inject contrast.
3 weeks, 4 weeks.
No, no. Answer the question. We don't want to comment. Leave it for 4
ठीक
weeks.
है. ठीक है. Okay ठीक है. That's it.
Or you just
Deflate.
leave it and leave it forever.
Out.
You would not check on it.
You won't check on it.
So, that's
My dear, then we have a problem. Because you don't want to leave anything. You want to leave. Remember, Dr. Khalid said pancreatic duct is very thin, very normal. You're putting we are using 5 French stents here.
Right. Okay. Thank you.
Pancreatitis ka risk is how long?
Thank you.
When do you have pancreatitis after ERCP? Within 24 hours? Okay, so make it a few more hours.
Right. Okay.
Make it 7 days, 5 days. In my opinion, anything after 3 days is fine. You took larger stents, so the quicker you take out, the better it
ये
is.
जरा हटा.
Okay, you don't want to leave it long and then end up having problems with either, in this case, you saw this is a single
हाँ
pigtail,
ग्लव.
so the chances of migration are not there, but there is no.
हाँ ना ये तो भाई मजे हैं ना.
Dusra, you know, the longer you leave a larger stent in a thin pancreatic duct, you're actually trauma, stricture formation,
हाँ, ये तरह
pancreatic
का
duct,
है।
it's very nasal. Okay, so
And even these pigtail, 9 out of 10 will pass, 1 will not. So you're gonna, if you leave it in, so out of 100 ERCPs, 100 pancreatic stents you placed, 10 of those are never gonna pass.
and mind you, when you read the literature, those stents are either 3 French or 4 French.
And mostly pigtail.
And
5 centimeter
Huh?
length.
Length is usually 3 to 5 centimeters, and they're small, 3 French or 4 French, so they are more likely to pass. Okay, the larger stent, the less likely it's going to pass. This may pass itself as well, but the percentage would be less than what Khalid is quoting if the stent size increases. Okay, so you can't leave it there. What you don't need to do is bring the patient for ERCP. You can always do a fluoro or a
No, what our practice is, the way we do is, like one thing we put a smaller stent, and second thing is, all of those patients get an X-ray in 4 weeks, just an X-ray. If the stent doesn't go, then you do a EPD, pull it out. If the stent is gone, X-ray will tell you that it's gone.
All my patients come back 7 days. Okay, they will have a check X-ray. If it's still there, we take it out. The reason for that is that their system is very controlled, structured, organized primary care, very good referral system. Patient can't go here and there. In our system, patient comes from all over, wherever. Dusra, they go, and they forget, like you said. And then we find out after some time that there was a stent somebody placed and it's still there. Okay, so in our practice, that's why I want to finish the job, because of the circumstances. Okay.
One of the problems here was that the stent they gave me was a bit too long, so I had to leave a bit of
So
it
they didn't
out.
give you a 5 French? 5 centimeters?
They got it was 75 cents, so it was cool. I felt it was a bit too long, so I only used part of it. It is going to fall out in the next 2 to 3 days, hopefully. So it should
That's what we were discussing here. I usually have a policy of we check it 1 week.
I mean, we all do that.
And 1 week,
Simple
if it's
plain
not out,
abdominal
and then we
X-ray.
then we take it.
Just simple abdominal X-ray, and you don't need an ERCP for it, just an OGD and pull out. इसमें fold था that was very accentuated. This was a very typical demonstration of what Dr. Khalid Hassan showed earlier. The fold was quite accentuated.
Hello?
And in spite of putting
Hello?
on it, because that's one of the ways of doing it.
Can you hear me?
I just couldn't get hold
We
of
have,
that.
seen, we have seen everything on ERCP.
Wasim,
Yeah, no, it was.
Wasim,
double wire.
अस्सलाम सर
हाँ बेटा वजन कम करो. अच्छा,
सर वसीम है
हाँ कुर्सी पे वजन बहुत है. सुनो, पेशेंट रेडी है?
यस सर
भेज दूं खालिद साहब को? खालिद साहब को भेज दूं?
नहीं सर मैं पेशेंट लेके मैं आपको इन्फॉर्म कर रहा हूँ सर.
Okay. Yeah, I think in one case, rightly said.
हमें नजर आ रहा है.
मैं उससे कह रहा हूँ कुर्सी पे थोड़ा वजन कम कर, उसको समझ में नहीं आया. Yeah, you're absolutely right. You saw a lot. You saw standard technique of cannulation. You saw a difficult ampulla. You saw a standard technique attempt. You saw repeated pancreatic cannulation. You saw pancreatic stenting. You saw double wire technique before stenting. That didn't work. You saw stent. Then again attempt. Didn't work. Then you saw needle knife. And then you saw stone extraction and completion. Okay. So I think in one case, you're absolutely right. You've seen a lot of steps that we discussed. Okay. Now, if you remember, the needle knife Vakar did was not star shaped. Okay, which you will all see. Their star shape hoti hai, not intentional. That's unintentional.
अच्छा अच्छा.
Because if the needle is going, that should not happen. He knew where he was. He knew where he was. He made one cut, waited. Sometimes you'll have a little bit of blood, washed, cleaned. Extend your cut from there. You don't have to go deep in the first row. Like Khalid said, you can dissect. The less your needle is out, the less chances of perforation.
Yes.
This is a naked gun. Okay. So you saw all that,
Sir?
and then you saw where the opening was. And you saw how the wire went through that opening and straight. We were in the CBD extension. He did not go, he normally does large, very large sphincterotomy. But he did a controlled sphincterotomy today because the force and everything was becoming a little unsure. So if you're unsure, stop. He attempted taking the stone out, which he successfully did. Otherwise, I'm sure he would have done a small sphincteroplasty and we would have got the stone out.
So since
But
there was a doubt,
in every patient, you have to treat every case as an individual case. Don't apply. This is not mathematics. Okay? And so, whatever we discuss will be applicable, may be applicable in one case and may not be applicable in another. Okay? So, you should know, like I said, you know what you need to do next if it's not working, next if it's not working. Those of you who reuse, obviously everybody here in Pakistan reuses, I'm sure. The problem with sphincterotome is that when you've used it a few times, you will notice that uski jo tip hai, wo thodi si rough ho jati hai. And that doesn't help in difficult cannulation. The smoothness is there. Similarly, wire. If your wire is not good, it gets stuck even in the sphincter. So although everything is right, but वो wire ही फंस गया है. आप कह रहे हैं wire नहीं जा रहा, अच्छा जा नहीं रहा, wire क्यों नहीं जा रहा? Wire इसलिए नहीं जा रहा कि the problem is not in the ampulla or bile duct, it's in the bloody scope and the cannula. So all these things you will learn with experience. I think they're important when we reuse things. And if you're stuck, as I said, you need to have all the tools. You can't do ERCP with one sphincterotome, one wire, one balloon.
Selection
and one stent set, because your stent set can go off like this, and if it goes, what do? The last thing you want to do in a case like this is inject dye, come out without draining. You inject it, you cannot leave that patient. You either put a drain yourself in the form of stent, or you send the patient straight for PTC. Otherwise, you'll have that patient go very, very quickly into severe cholangitis, septicemia, multi-organ failure, and probably death. Okay. So if you are going to inject in a closed system and you can't drain, get your radiologist, get someone to sort that out as soon as possible. Don't leave it for go settle ho jayega, IV antibiotic de denge, Marinum de denge, or Tavocin de denge. Don't do that. So you don't inject. That's why in my practice, I don't inject now. Unless almost, majority of the cases, my wire's got to be in, my cannula is in, that's when I start injecting. Unless like we discussed, it's a difficult case, he was trying, he needs to know where the pain, that's a different thing. Okay, but if I can, I would try and put a wire. And wire is very easy now, you can see it going into CBD, so why do you have to inject? Put the wire first, get the cannula above the stricture, then inject, you know already you're safe.
so since there was a stent in PD, right? Then we had pre-cut. It's also called pre-cut or it's not
Yeah, it's
pre-cut?
needle knife. You cut the ampulla without the sphincterotome, it's needle.
So the size of the balloon to stone attraction, how to decide which one to use and how much to inflate?
Balloon size for removing stone.
Yeah.
You have balloons that come with 3 gradual things. So you can go 8.5, 1.2, 1.5, right? And there are some that are standard 1.5, 8.5 is separate, 1.5 is separate, and 1.2 is separate. If you have the one which is like the 3 graduated ones, and the duct is not too big and the stone is small, you really don't need to do too much. Okay? But if the duct is like not very big and you put a 1.5, it's not going to harm you with that balloon, but it will just make it difficult and patient will have pain as well. So you go according to the duct, according to the stone. If the stone is small and the duct is big and you only inflate a little bit, this balloon will pass alongside the stone, you'll not be able to take it out. So this is more common sense than anything else. For sphincteroplasty is different, but we are not teaching sphincteroplasty.
Secondly, it was quite a big stone. When you looked at the cholangiogram initially, it looked like a stricture, and that's because there was not much contrast going around it. So that's why we had to re-inject to get a better projection.
Initially, I also thought it was a stricture because of what linear submandibular. And that's why he was not able to get it. Because the stone was probably just above
Sitting
the
on the
thing and sitting there, so it wasn't allowing you to get it. Any other questions while we are waiting for the next? The problem with ERCP is we only have one floor. So it's not like we have two rooms where we can say, okay, fine, move to the next. Ready? Okay. Khalid sahab aa rahe hain. Okay. वो एक को आप निकालो ना करना क्या सब कुछ निकालो नहीं उनसे बोलो जैसे ये केस खत्म हो गया यूएस में हाँ वो मैं इस पे नहीं करूँगा वी नीड टू डू अ वेरी क्विक कर दूँगा खत्म होने दो इसके बाद अगर
Can you hear me?
then we'll take this bike.
Hello.
And we'll run for the course.
ऐसे spyglass वाला भी demonstration.
Hello.
Hello. Ji, we can hear you, beta.
Hello. Can you hear me?
Yes, we can hear you.
This is the next patient for ERCP. This 28 years old female patient, Anila, with no comorbids. She admitted with history of pain in right upper quadrant of abdomen for 1 week. Is associated with nausea and vomiting, and she has a single episode of such complaints for 1 year back. She was diagnosed with cholecystitis secondary to cholelithiasis. And she was treated conservatively and she denied surgery. At present, clinically, she is not anemic or jaundiced. Abdomen is soft, non-tender, while her workup includes ultrasound, which demonstrates cholelithiasis with cholelithiasis. CBD is dilated. It measures 1 cm in diameter with 3 stones. The larger one is 0.9 cm impacted in distal CBD. While her LFT includes total bili is 0.5, while alkaline phosphate is 308, while INR is 1.05. Thank you.
Yeah, thank you. Khalid, can you hear me?
I can hear you. Can you hear and see me or
Yes,
not?
we can hear you and also see you. I'm sorry, but I've given you a patient without propofol only for today.
That's okay. All
That's
manage.
going to take you,
What do I do?
I don't know, when was the last time you did an ERCP under sedation, but good luck. They use propofol and all.
Sir, one question.
Sir,
If you
patient
have
has
to put the stent right in the previous case, if you have to put the stent in previous case that he did, what would be the size of the stent? Like how you going
Which stent?
consider?
No, but where?
If the stone would have been bigger, suppose.
Oh, what size of stent? I'll tell you how I calculate size. Anything up
Can
to
you
the
see me?
10, 9 is fine.
Hello?
10 centimeter.
इसको जरा लूप लगा दिया.
Ji Khalid?
Gigi, can you see me?
Yes, we can. So we'll be with you.
Okay, no,
Focus on this, we'll answer your
yeah, I just want to show, is there a light jala hai na? Okay. So I just want to show you how to hold the scope. Yeah, like here you see that the scope is gonna rest on my palm. The wheels should be facing up like this, and you hold the scope like this and use this finger for the suction and air button. Scope is gonna go in. So I gently am moving, rotating my scope gently. You can see I'm going through the esophagus. When I'm going through the esophagus,
Can we have the endo picture? please?
endoscopic view, please. You see that? You have endo?
No, now we are.
Okay. So I'm very gently going through the esophagus. Some of these patients are gonna have stricture, so you really need to be very gentle when you are going through the esophagus. Just make a habit in every ERCP that just go very gently through the esophagus. It's going to take 2 seconds extra, but you just try to go gently in there.
That's a very good point, Khalid.
Okay. So I'm into the stomach. If you look at the stomach, it's kind of a little bit J-shaped, but that's not a big problem. We'll manage it, and now I'm going into the antrum. इसका sedation थोड़ी और कर दो. She's struggling a lot. So whenever you go through the stomach, you push the scope or advance the scope into the antrum. That stretches the stomach, and whenever the stomach is stretched, patients feel a lot of pain, especially if they are not in propofol sedation. So it's just a general sedation. Every time I'm trying to go in a little bit, she's trying to push me away. But you see the pylorus right there? I will go. Yeah, I will go into the pylorus very gently. I got into the duodenal bulb. I stop there and I rotate my scope a little bit to the right. Can you put that on my hands, please?
Yeah, we can see your hands as
Okay.
well.
So I'm going, I see that right there opening. I'm going to move the big wheel towards me. What that does is that takes my scope through the duodenal apex. I didn't advance the scope. I just moved the big wheel towards me. Now I will move the right small wheel away from me. I didn't do anything else yet except these two maneuvers. So now the wheels are going to face me and I will gently pull the scope back. Do you see something unusual there? Or usual?
Usual, not so unusual.
Okay. So you saw the minor papilla right there, right? And here, now I'm right onto the ampulla. I will freeze that image. You see the opening right there. You see a fold right on top of that. There is a second fold on top of that. And there is a diverticulum right above that. You see that? And here, if I can maintain that position for my cannulation, right there, this would be a beautiful position at least. We'll see how the cannulation.
I selected this one specially for you, Khalid.
Oh, I appreciate that. So here, one other thing, just please make sure that I don't think anybody was as tall as Waqar Bhai and Saad Bhai there. So what you need to do is they can stand very close to the patient and still their scope will be straight. What I do, I move away from the patient because I'm short in height. Purpose is to have this scope really straight. You see that? There is no, this is not a good position right here because anything I do is not going to be transmitted to the end of the scope. So I have to stay away. So
Keep
if
the room position.
yeah,
Room position. I want to see Dr. Khalid.
Can you have the?
Not X-ray. I don't want fluoro.
We don't need the X-ray yet. I'll tell you when we need the
Uh-huh.
X-ray. Okay. So here, what I do is I step away from the patient. So my scope is completely straight. You see that, how straight that is? I don't want to be here because then I can't do what I really want to do with this scope. So I will move back. My scope is straight. My angle is straight. Wheels are facing towards me. If these wheels are facing towards me and I put those on my chest, I can do whatever I want. My scope will not fall back. The reason is it hugs around the duodenal apex. So I can stand here, I can ask him, give me this, I can talk to anybody. My scopes, even though it may move a little bit right and there, but it will not fall back into the stomach. So when I do a spyglass goes through the working channel, the scope is going to fit here. I will lock my wheels most of the time, both wheels, these wheels facing towards me, and I hold the scope from here. So that way, so I can work on my spy scope. So most people, they want to hold it from here. I don't need this for my spy scope. The reason I'm telling you this is because when I'm using spyglass, if wheels are facing towards me, these are locked, I will not fall back into the stomach, so I can keep working on that. It's not going to be always 100%. Sometimes you still may fall back, but as long as the wheels are facing towards you, the scope goes around the duodenal apex, and it kind of hugs and does not fall back. Okay? Any questions?
No, I guess not. We're just waiting for you to.
Do something?
Yeah.
Okay.
Actually, the ampulla is asking you to do something.
That's the plan. Let's see. So here, I usually have my tech who controls fluoro, but I know here I have to control it myself. So here I can.
Somebody will control your fluoro if you want.
No, that's okay. Right now, everything is in good position. I can use a wire tip, and you see the angle. What I really want to do is like bring that straight papilla to me right here. If I go in like this side, I don't have to use wire tip. I can use wire tip if needed, but if I can maintain this position right there, big wheel towards me, should be in. So it's a very easy cannulation. I think you cannot compare this with the previous case. Fluoro किधर है? Okay, इसको ज़रा थोड़ा सा नीचे move करो. वो जनाब पहले ही पहुंच चुके हैं बाइल डक्ट में बगैर मुझे बताए. So it's like a very easy cannulation. You can see that it's a nice cannulation, so no problem with that. Here, G.
हम लोग की अक्सर bet होती है because when he puts the wire, he tells me I'm sir CBD, and then I say no, you're wrong. It's pancreatic.
No, he's never wrong. That's Wasim is always right.
Yeah, he's usually not wrong, except when it's money.
Okay. So here, let's go ahead and do the injection. And the injection version. So you see there is a stone up there and it's moving down now. So you see the stone there?
Yes, Khalid, we can see it.
Okay. I'll go ahead and do a sphincterotomy now.
That's coming down. You follow it.
ठीक है, मैं ज़रा exchange करें ज़रा. You moved it up. Okay, ठीक है. तो यहाँ पे you don't have to bore too much the wire. My goal is to I wish I could. Can you please point with the pointer that what should be the direction of my sphincterotomy so
Yes,
they can
I'm
see?
doing that.
Okay. Ready?
Should go like this. Fold cutega ये. This fold is part of the. Yeah, you see, he's not moving. In one cut, we were not moving. He's not moving right, left, and center. There's no star. Okay.
So this is a other thing. I'm gonna freeze it here. You see the muscle? It's completely cut all the way from the top. And on the top, you don't see any muscle. So this is a full sphincterotomy. That's how it should look like. And you see that right there, you can even see inside the bile duct. I don't see any muscle left there. You agree?
Agreed.
You see the muscle right there. I froze it. That's a sphincter muscle. And you don't see that on the top. Balloon there. Ready for exchange? And here, if you look at my position, I am kind of facing a little bit away from the patient right now. And not away completely. This, even though the monitor is on that side, but my monitor in my unit is here. So that's, I like to see in this direction. And that keeps my scope in the right position.
There should be a monitor in front of you as well.
Yeah, there is one here, but I think I can take a, I want you to see me too, that's why.
We don't mind that either.
Okay. Yeah,
So Khalid, when do you use basket?
okay, so basket actually I would use for a bigger stone and a little bit bigger. And also if I think like it's not gonna come in one piece, I may have to crush it. And also if I have to really go maybe into the intrahepatic, sometime I will use a basket for that reason. So if it's a good size sphincterotomy, stone is small, I will just use a extraction balloon. One thing I want to show you is how to maneuver the scope and how to extract the stone and what should be the scope position. I want to show you that in just a second. So here, so we will start from here, okay? I think stone is down, but we'll go ahead and inflate the balloon. Block kar diya? Haan ji. Okay. You see it's a balloon is right there. I'm gonna pull it down, pull it down, pull it down, pulling it. So here, I feel a little resistance. So with the scope, I'm gonna make that 7, like upside down 7. Somebody mentioned that earlier, that 7. So I'm gonna try to do that. And after that, is the camera on my hands, please? I want to.
No, yeah, that now we can see it.
Okay, can you see it?
Yeah.
Okay. Can you show fluoro, please, at the same time? See the fluoro yet or no?
Yeah, we can
okay.
see the fluoro and your hand.
So here, balloon is really tight now, okay?
Yeah.
And it's kind of hugged against the scope, okay? Yeah. What I do is I hold the balloon with my pinky. Sometimes I rotate it like this and hold it really tight. So fluoro again, please. Actually, camera is on me, right? Camera is on me?
Yes.
Okay. So
but your hands we can't see.
Okay,
so
I
tell
need
them to focus on your hands.
यार मेरे हाथों पे ना मेरे इस पे हाँ. Can you see me those now?
Not the hand.
Okay, थोड़ा सा और नीचे करो.
Now.
Now you can?
Yeah.
Okay. So look at the scope position. It's
yeah. We can
scope.
See it.
Yeah. Its scope is coming like this,
yeah.
and the balloon is like that.
Yeah.
So the whole scope, I'm gonna keep it on now. So I'm gonna gently push the scope in and rotate to clockwise. You see, or go to the endo quickly, please.
Endoscopic view. There's the balloon as well.
Do you see the balloon?
Yeah.
Okay, deflate the balloon. I'm gonna just pull my scope back. And you see, I did not lose anything there, okay? Now I go back there. What I'm trying to show is like scope has to move like a single unit. It's not the balloon moving out only. Scope has to go in and you're gonna rotate a little bit to the right and scope should move like a single unit with the balloon. Again, I'm gonna demonstrate that. Inject करना जरा. Inject करते जाओ, करते रहो, करते रहो, करते रहो, करते रहो.
Right system as well.
Okay, balloon up.
There's still a filling defect on it.
Right below the.
Yeah.
Okay. वो आ गया stone बाहर. Balloon down. You see the stone?
Yes, we can.
Right there? Okay.
Yeah.
So I still did not, I did not lose my position from the bile duct. So it has to come as a single unit. I cannot stress that enough. It's not like a fluoro, inject karo zara. Okay. It should not be, balloon up, sorry, balloon up. It should not be like this, just coming down like that. Now it's very big opening. It's coming it easily, okay? Balloon up, यहाँ पे दोबारा. Balloon up, okay. Balloon has to be up. You're gonna move the scope towards the ampulla. Balloon is gonna come really close to the scope and look at the scope, how it moves and how the balloon comes out.
You saw that?
Yes.
Okay.
It's quite clear.
Okay, good. I think we're done here. Balloon down.
Thank you. Good job, Khalid. Can they set up the spyglass? Do we have time? We have about half an hour. So we've got about 1 hour actually. 5:30 tak
Chale,
chalta.
thank you.
We started a little late. Wasim. Yes sir. Spyglass set करने में कितनी देर लगेगी? 10 minutes. हाँ? 10 minutes. 5 minutes.